Today, we're going to talk about the need to localize lesions within the central and the peripheral nervous system as a way to further hone down or narrow the differential diagnosis of the multitude of entities that can cause problems in infectious and tropical neurology. As you've already learned, when the nervous system was developing, several divisions of the nervous system formed. Individual lesions of each of these different levels of the nervous system produce very discrete and expected findings on a neurologic exam, as well as symptoms voiced by patients. It's therefore possible to localize lesions within the nerve axis to these different levels of the nervous system. And fortunate for us, different disorders affect each individual level of the nervous system. A complete neurologic examination, when performed in entirety, should assess all of the different levels of the neuraxis as we talked about just previously. Now, this is a picture of the left hemisphere of the brain, and you can imagine that it's somewhat like a computer. Sensory information comes in, and there's an output that is expected. The natural lobes of the brain are identified by the lines on this brain, and you realize that the frontal lobe is in front, the temporal lobe is inferior, the parietal lobe is superior, and the occipital lobe is in back. The sensory strip, or the sensory homunculus, lies on the postcentral gyrus, just posterior to the vertex of the brain. Anterior to that, or one gyrus forward, is the precentral gyrus, and that's where the motor system, or the motor homunculus, lies. Now, if we look at the motor homunculus on the precentral gyrus of the frontal lobe, we see that it descends all the way down the brainstem, through the spinal cord, where it synapses on a different neuron called the lower motor neuron. Now, there's a somatotopic organization to both the sensory strip and the motor strip of the cortex. The motor strip lies in the precentral gyrus of the frontal lobe and contains a somatotopic organization whereby different portions of the body are represented in different degrees on the surface of the brain. And the same analogy is true for the postcentral gyrus, which contains the sensory homunculus. These ascending sensory fibers will disperse on the surface of the brain. The descending motor fibers will coalesce. They all run through the subcortex and down deep through the brainstem and spinal cord. Smaller lesions deep in the subcortex have the ability, therefore, to wipe out or ablate all of the fibers that will disperse to the motor strip and to the sensory strip. If we take the brain that we were just talking about and we superimpose it on a human face, we can actually see that there's a highly eloquent area on the left surface of the brain, just superior and anterior to the ear, and that's Broca's and Wernicke's area. Just anterior to Broca's area is the frontal eye fields, which, when stimulated, drive the eyes in the opposite direction. So lesions of the cortical brain, therefore, classically produce seizures, because irritations of the cortex of the brain tend to produce epileptic seizures. We'd expect to see sensory changes and motor changes in expected distributions. We often use vascular lesions to exemplify this. The middle cerebral artery feeds the lateral convexity of the brain, for example, and so lesions of the middle cerebral artery classically produce face and arm more than leg, sensory and motor changes. By default, the anterior cerebral artery feeds the middle aspect or parafalcine region of the brain, which is where the leg is represented on the motor and the sensory homunculi, and therefore lesions of the anterior cerebral artery classically produce abnormalities of the leg more so than the face and arm in regard to motor and sensory modalities. Finally, if the surface of the brain is lesioned where the frontal eye fields are, the patient could have eye deviation abnormalities. And if Broca's or Wernicke's areas are lesioned on the left dominant hemisphere of the cortex of the brain, then aphasias could occur. So in general, lesions of the cortex produce aphasias, apraxias, agnosias, neglect, and expected abnormalities of frontal eye fields and of the motor and the sensory strip. Now, if we look at a patient's CT scan, and this is a coronal cut of the CT scan, we can identify that the subcortex lies below the cortex. The subcortex contains these converging fibers of the motor strip that are descending down to inferior levels of the brain. The subcortex also contains the ascending sensory fibers that will coalesce and terminate on the postcentral gyrus of the parietal lobe. Lesions that are deep in the subcortex, therefore, have the ability to equally affect the face, the arm, and the leg in regard to both sensory and motor modalities. So we often expect that subcortical lesions will produce face equal to arm equal to leg, motor and sensory abnormalities. And because visual radiating fibers run through the subcortex, we often expect to see visual changes, perhaps a homonymous hemianopsia or an inferior or superior quadrant defect. Now this is that same brain again, cut in a coronal section, and now I'm going to identify the midbrain, the pons, and the medulla. And together these represent the brainstem. And we call the brainstem, as well as the left hemisphere of the cortex of the brain, high-priced real estate. It's high-priced real estate because you can't really afford to mess around with it. Lesions of the left dominant hemisphere cortex can produce lesions of Broca's and Wernicke's area. Lesions of Broca's and Wernicke's area can produce the inability to ever understand spoken language or to ever generate spoken language. And so lesions of the dominant cortex of the left hemisphere have the ability to disconnect a patient from spoken word. Lesions down deeper in the midbrain, the pons, the medulla are equally as devastating, but for different ways. In the midbrain, there's something called the reticular activating system. It's a reticulated network that ascends in the brainstem, and it keeps you awake and alert. Lesions of the reticular activating system, therefore, can make patients become somnolent and comatose. If we go one step more inferior to that, we're at the level of the pons. Bilateral lesions of the pons have the ability to produce something called locked-in syndrome. Locked-in syndrome allows for a person to maintain preserved cognition and the ability to perform vertical eye movements, but the inability to perform horizontal eye movements or any movements inferior to this. In general, locked-in syndrome produces, therefore, a conscious person who is trapped in a paralyzed body that cannot move. Finally, a lesion of the medulla has the ability to affect cardiorespiratory centers. Lesions here can produce fatal arrhythmias, complete asystole, and can change a patient's ability to breathe and can take away respiratory drive. So lesions of the midbrain produce coma, lesions of the pons produce locked-in syndrome, and lesions of the medulla produce cardiorespiratory collapse. And so now you can understand why the high-priced real estate of the brain actually means something. Now, when a neurologist looks at the brain, we look at the brain from a north and a south and an east-west perspective. And so if we drew an axis on the brain, it would look something like this. And we know that the y-axis defines caudal from rostral. I've drawn natural divisions on the brainstem here. You can see where the midbrain, the pons, the medulla lie. Defining cranial nerve involvement localizes on the y-axis. Defining left from right lateralizes on the x-axis. Cranial nerves 3 and 4 exit out the midbrain. 5, 6, 7, and 8 exit the pons. 9, 10, 11, and 12 exit the medulla. And so you can imagine, therefore, that if cranial nerve lesions produce ipsilateral findings, once you see a cranial nerve abnormality, you understand if this lesion is on the left versus on the right. An example of this would be a right-sided hypoglossal nerve lesion, which would produce tongue deviation to the right. It would help you immediately understand that this lesion lies on the patient's right side of their neuraxis. Cranial nerve lesions always produce ipsilateral findings. In general, we don't talk about the fourth nerve very much when we think about this maxim or caveat, because the fourth nerve does indeed cross. And so for all intents and purposes, doctors tend not to talk about the fourth nerve very much, with one exception, that when lesioned, it produces head tilt. Now, if we look at this brain again in coronal section, we have to remember that there are long tracts or highways that run north and south. There are 2 sensory tracts that ascend from south to north, and there's one descending tract that descends from north to south. The 2 sensory tracts are called the spinal thalamic tract and the dorsal columns and medial lemniscus. The one motor tract is called the corticospinal tract. If we focus upon the 2 ascending sensory tracts, we see that each of them crosses at different levels of the nervous system. And this is now becoming the basis of further localization within the nervous system. The one motor tract also decussates or crosses from one side to the other, and it crosses at an area that we call the pyramids of the medulla. Let's focus upon pain and temperature, the one sensory tract that, as it enters the spinal cord, decussates or crosses immediately, and then arises north until it terminates on the postcentral gyrus of the parietal lobe. Contrast that with the other ascending sensory tract called the dorsal column medial lemniscus. This tract enters the spinal cord, arises and stays ipsilateral, and does not cross until it reaches the cervical medullary junction, where it crosses to the contralateral side, and then too ascends until it reaches the postcentral gyrus of the parietal lobe. The motor tract descends from the motor homunculus of the precentral gyrus. It decussates at the pyramids of the medulla, and then descends contralaterally from the site of origin until it synapses on a neuron that will leave or exit the central nervous system. Once we start to superimpose cranial nerves upon these three highways, the one descending motor and the two ascending sensory tracts, now we can start to finely localize within the nervous system. In this photograph, I've taken the liberty of placing cranial nerves 9, 10, 11, and 12 and juxtaposing them to the corticospinal tract and next to the dorsal column medial lemniscus tract and next to the spinal thalamic tract. Now, remember that when I'm showing you these different tracts, I'm only showing you tracts on one side of the brain. The reality is that these tracts are present bilaterally, and so keep that in mind whenever you're localizing lesions to the central and peripheral nervous system. Let's focus again on the dorsal column and medial lemniscus tract. It carries vibration and proprioception from peripheral sensation all the way up to the cortex of the brain. It decussates where the brain stem becomes cervical spinal cord. The spinal thalamic tract carries pain and temperature. It decussates immediately upon entering in the spinal cord. If you superimpose both of these ascending sensory tracts together, it's very easy to see that they are disparate, or they run separate in space, at least in the spinal cord, until they come together actually at the top of the pons, or the rostral pons. So this space in the spinal cord and up to the rostral pons allows both tracts to run separate. It's therefore possible that a small lesion could affect one tract and not the other. Lesioning only one tract will produce an abnormality called sensory dissociation. And it's a very important concept in tropical and infectious neurology because there are several disorders that have a proclivity towards lesioning only one of these two ascending sensory tracts. The most classic examples that you've learned already are syphilis and vitamin B12 deficiency, both of which have a tendency to lesion the dorsal columns, but not the lateral spinal thalamic tract. Let's look at the brain in a little bit different way. I'm going to focus now upon the descending motor tract. The descending motor tract has its cell bodies that lie in the primary motor cortex of the precentral gyrus of the frontal lobe. The cells are organized in a somatotopic organization such that the face and the arm are located laterally on the convexity of the brain and the leg is located medially along the parafalcine region. These fibers descend through the subcortical fibers, which we call the corona radiata, and go through the brainstem and then decussate to the contralateral side where cervical spinal cord and brainstem meet. This primary motor cortex contains cell bodies that are called giant. So this tract, which has its origins in the precentral gyrus of the frontal lobe, will descend through the corona radiata, or deep white matter fibers of the subcortex, pass through the brainstem, decussate to the contralateral side where the brainstem becomes the spinal cord, and will descend to the point where it synapses with the lower motor neuron that exits the central nervous system. This entire tract is called the pyramidal tract. It's called the cortical spinal tract. It's called the upper motor neuron. It's called the motor tract. And so you have to remember that it goes by all of those names whenever you're reading about medical literature. This motor tract decussates at the pyramids of the medulla. And so a lesion above the decussation will produce contralateral deficits. And therefore, by default, a lesion below the decussation will produce ipsilateral findings. We've talked a little bit about localization of the cortex and of the subcortex. If we go one step further, now we're in the brainstem. The brainstem seems so complicated to most patients and to doctors, but in reality, it's quite simple. The brainstem is the spinal cord with cranial nerve nuclei embedded within it. So whenever you lesion the brainstem, you expect to see long tract findings. The long tracts being the two ascending sensory, and the one descending motor tract, as well as cranial nerve nuclei. Lesions that affect the long tracts in the cranial nerve nuclei allow you to localize the lesion immediately to the brainstem. And you know that the brainstem now is comprised of the midbrain, the pons, and the medulla. You have to remember, therefore, that the bottom four cranial nerves, or cranial nerves 12, 11, 10, and 9, exit the medulla. The next four cranial nerves exit the pons, 8, 7, 6, and 5. The next two cranial nerves exit the midbrain. And so it's important to remember not only the names of the cranial nerves, but also their functions. And so this slide right here shows the functions of the cranial nerves. So a patient, for example, that has difficulty with vertical eye movements will have a lesion in the midbrain because cranial nerves 3 and 4 largely move the eyes up and down. A patient who has a lesion of the pons will classically have horizontal eye movement abnormalities because that's where the sixth nerve lies. So there are large caveats that you can apply to the localization of lesions in the brainstem. Vertical eye movements localized to the midbrain, horizontal eye movements localized to the pons, etc. I didn't mention a whole lot about the cerebellum, but the cerebellum lies just posterior to the brainstem. Its close proximity and the afferent and efferent neurons that juxtapose the long tracts and the cranial nerves often allow one to see cerebellar findings alongside long tract findings, even though the long tracts do not run through the cerebellum. As you might remember from neuroanatomy class, the cerebellum is incredibly complex. There is no one single medical or diagnostic test that evaluates the integrity of the function of the cerebellum. I came up with a mnemonic that helps me remember the abnormalities that I should always look for in a lesion of the cerebellum. And that mnemonic is HANDS tremor, H-A-N-D-S-T. The H stands for hypotonia or low tone. The A stands for ataxia. The N stands for nystagmus. The D stands for dysmetria, dysarthria, and dysdiadochokinesia, or abnormalities of rapid alternating movements. S stands for abnormalities of stance and gait, and T stands for tremor, which usually is evidenced when patients are performing finger to nose. It's important to remember that the basal ganglia and the cerebellum both modulate the descending motor tract, or the corticospinal tract, or the pyramidal tract. Lesions of the basal ganglia produce very expected and different findings than lesions of the cerebellum, and I've listed these out here for you. So it's important to remember how the basal ganglia lesions manifest clinically and differently from lesions of the cerebellum. Let's go one step inferior now in these levels of the neuraxis. We've talked about the cortex, which gives you aphasias, apraxias, agnosias, neglect, and seizures, and a somatotopic abnormality of motor and sensory modalities. We've talked about the subcortex, which contains visual radiating fibers, and when lesioned, equally produces abnormalities of face and arm and leg in both motor and sensory realms. We've talked about the brainstem, which lesions the 3 long tracts, the one descending motor and the 2 ascending sensory, along with cranial nerve abnormalities. And now we're one step inferior to that, and we're talking about the spinal cord. It's easiest to think about spinal cord lesions when you think about the fact that lesions of the spinal cord can produce transections. And so abnormalities of the spinal cord classically produce horizontal findings with abnormalities below the level of the lesion. Because the spinal cord contains these long tracts of the 1 descending motor and the 2 ascending sensory, you expect below the level of a horizontal lesion in the spinal cord to see abnormalities of sensation and abnormalities of motor. And we'll talk later a little bit about the abnormalities of motor being upper motor neuron related as opposed to lower motor neuron related. In addition, the spinal cord also contains descending autonomic fibers. And so classically, spinal cord lesions produce a horizontal level of bilateral lower extremity, or if high enough, all 4 extremity, upper motor neuron related weakness and sensory changes. And in addition, we often expect to see abnormalities of autonomic function, which could be bowel or bladder, retention or incontinence, erectile dysfunction, and other abnormalities that can include things like piloerection. Spinal cord lesions are not common, but they are very important to pick up because they have a high risk for producing disability. Now, we've talked about several levels of the central nervous system so far: cortex, subcortex, brainstem, and spinal cord. And now this is where I draw a line in the sand, because now once I start to talk about the further levels of the nervous system, I am out of the central nervous system and now talking about the peripheral nervous system. And so lesions at the level of the spinal cord and above, if you're lesioning the motor tract, will produce upper motor neuron abnormalities, which can include increased muscle tone, which we call spasticity, increased reflexes or hyperreflexia, that can include clonus, and the presence of Babinski sign. Lesions distal, however, to the spinal cord produce a different pattern of motor involvement, provided that the tract that you're talking about contains or conveys motor fibers. And so lesions peripheral to the spinal cord produce lower motor neuron findings of weakness. You get atrophy or loss of muscle bulk, fasciculations, which look like small twitches underneath the skin, reduced or absent reflexes, and low muscle tone. When we talk about lesions now distal to the spinal cord, we're talking about the spinal nerve roots, and lesions of the spinal nerve roots are called radiculopathies. There are two spinal nerve roots at every level. There's a dorsal root and there's a ventral root. The dorsal root contains sensory fibers or sensory input, and the ventral root contains only motor output. So a lesion of the dorsal spinal nerve root would produce a sensory strip of abnormality in the body that is called a dermatome strip of abnormality. A lesion, however, of the ventral spinal nerve root would not produce any sensory changes. It would only produce weakness in a classic distribution called a myotome. So dorsal spinal nerve root lesions produce dermatome abnormalities of sensation, and ventral spinal nerve root abnormalities produce motor weakness in the pattern of a myotome. And remember that a myotome pattern of weakness is different than a pattern of weakness that you would see from, for example, a distal peripheral nerve lesion. Finally, if that area or level of the spinal nerve roots conveys a reflex that you check, such as the biceps brachii, brachioradialis, triceps, patellar, or Achilles reflex, then you might see a reduced reflex or even an absent reflex. Remember that a lesion of either the dorsal spinal nerve root or the ventral spinal nerve root either could reduce or completely ameliorate a peripheral deep tendon reflex. A schematic drawing is shown right here where a lesion of the dorsal spinal nerve root is indicated in yellow and would indicate a lesion here producing a sensory abnormality in the distribution of a dermatome. And conversely, the colored abnormality is indicated by the arrow, shows a lesion that would produce weakness in the distribution of a myotome. Now, in my own mind, since I practice in Kenya and Uganda and Tanzania quite a bit, I always think of zebras, because zebras have a classic strip-like change to the color of their skin. And these are, in a way, a reminder for me as to what a dermatome might look like. I'm not telling you that the stripes of a zebra are consistent with dermatomes, but they give you an idea of how the sensory strip-like changes from a dermatome abnormality might look on a patient. Now, there's a lot of different ways to lesion the dorsal and the ventral spinal nerve roots, and one of those ways is herniating discs. And so we always remind students that one of the classic ways to check for cervical herniating discs is to apply axial pressure to a patient's head. Applying axial pressure can produce distortion of the disc, which has the ability to laterally herniate. And if it touches the dorsal spinal nerve root, can produce sensory pain in the distribution of a dermatome. Sperling's sign therefore implicates a disc that is herniating and touching a dorsal spinal nerve root. Myotomes are important to know. Every doctor needs to know the classic levels of the myotomes of the cervical spine and the lumbosacral spine. If you think about the fact that the upper extremity receives its innervation from C5, C6, C7, C8, and T1, it's important to know what the myotomes are for each of those levels. So when I personally do a neurologic exam on any patient and I'm checking motor strength, I check all of the myotomes of the cervical and the lumbosacral spine because it automatically allows me to clear a spinal cord lesion. A C5 myotome innervates the deltoid muscle, and so asking the patients to abduct their arms and assessing the resistance of the deltoid assesses for C5. C6 is best held by having the patient hold their hand in neutral pistol grip and asking the patient to resist flexion. This is testing the brachioradialis muscle, which flexes the elbow. C7 largely innervates the triceps, and so asking the patient to extend the elbow against resistance is a test for C7. Checking C8 is a little bit more difficult. You ask the patient to make a boxer fist and to flex their wrist, and the examiner tries to extend the wrist against the resistance from the patient. The patient's strength, therefore, is being assessed by asking them to keep their wrist flexed, and that is assessing the strength of the palmaris longus. Finally, T1 is assessed by asking the patient to touch the thumb and the pinky finger together, and the examiner attempts to break the strength of both of them touching together. That is assessing thumb opposition and is the best test for T1. If we move to the lower extremities, we can also check the myotomes of the lower extremities. And perhaps maybe these are more important to check than the upper extremities because lumbosacral lesions are so common. L2 innervates the iliopsoas, which produces hip flexion. L3 innervates the sartorius muscle, which produces hip adduction. L4 innervates the quadriceps femoris, which produces knee extension. And L4 is easy to remember, 4 quad, knee extension. L5 innervates the anterior tibialis muscle and allows one to dorsiflect the ankle. S1 innervates the gastrocnemius and produces plantar flexion. A patient, for example, who had a lesion of L5 would have foot drop. A patient, for example, with an S1 ventral spinal nerve root lesion would have weakness in a myotome that would prevent them from walking on their tippy toes. Now, if a spinal nerve root that is lesioned carries a reflex that we traditionally check, then you might actually see a reduction or absence of the deep tendon reflex that's being checked. Every doctor has to remember that there are 3 deep tendon reflexes in the upper extremities and 2 deep tendon reflexes in the lower extremities. I do understand that many of you may have read books that will tell you that different deep tendon reflexes localize better to one level or another, and there is, in many respects, discrepancies in medical literature. But in general, what I teach my students is that the biceps brachii reflex, which is assessed here in this picture by applying pressure to the biceps brachii tendon and with a quick strike of the hammer assessing the briskness of the flexion of the elbow, is the best test to assess for the C5 spinal reflex. C6 is a little bit different. You take your hand and you teeter-totter it on the distal aspect of the radius. And what you're doing is you're placing your hand over the brachioradialis tendon. And with a quick strike of the hammer over your fingers, you look for flexion of the elbow via the brachioradialis. The brachioradialis muscle receives innervation from C5 and C6, but by many textbooks, it's believed that the brachioradialis has a bit more C6 function than C5 function. So they're complementary. Biceps brachii C5, brachioradialis is mostly C6, and by default, triceps is mostly C7. Triceps reflex is tested quite similarly. You apply pressure to the tendon of the triceps reflex, and with a quick swing of the hammer, you look for extension of the elbow because of triceps contraction. If we go to the lower extremities, we really only check in general 2 deep tendon reflexes, although neurologists and neurosurgeons actually check many more. There is an L4 reflex, which is called the patellar reflex. The patient should ideally be in sitting position. You can assess the patient when they're lying down, but it's important to remember that whenever you check a deep tendon reflex, every joint above the reflex that is being assessed must be flexed. And so in this situation, The cartoon shows a patient sitting down on an examining bed and with a quick swing of the hammer, hitting the inferior and lateral aspect of the patellae, produces contraction of the quadriceps femoris, which produces extension of the knee. And finally, the S1 reflex, which is assessed here in a patient who's in supine position. Notice that the hip is flexed, the knee is flexed, and the doctor is passively dorsiflexing the ankle so that way it is cocked up. And with a quick strike of the hammer to the Achilles tendon, you're looking for contraction of the gastrocnemius that would produce plantar flexion of the foot. It's complicated, isn't it, in many ways? You can imagine that you can have lesions in the central nervous system and in the peripheral nervous system. It reminds me of a concept from Italian Renaissance art. Many centuries ago, artists didn't have a whole lot of money, and they would often repaint over old paintings that they thought were inferior. There's a wonderful example of this by Pablo Picasso on a painting that he repainted in 1903 called The Old Guitarist. It's one of my favorite paintings. Pablo Picasso actually painted this painting over an old painting. If you actually focus upon this portion of the picture and you blow it up, you can see the face of a woman. And such is the way the neurological system is. There's a layering of upper motor neuron on top of lower motor neuron findings. A good physician has the ability to see this pentimento, this repentance, or this layering of findings through the physical examination and the history. And so keep that in mind as you're examining a patient. Now there's a few major caveats as you go out to practice medicine. Number one, the pupillary light reflex screens horizontally in the nervous system, and Babinski screens north and south. So two of the most important neurologic examinations that I do is I shine a light in someone's eye and I stroke the bottom of their feet. Remember that in comatose patients, an abnormal pupillary light reflex usually implicates a structural lesion. However, in metabolic coma, a pupillary light reflex is usually preserved. You might use this concept as you're making clinical decisions regarding whether or not to image the brain of a patient under extreme resource limitations. Next, remember that you're going to see a lot of patients coming into triage who are comatose, and often you will have no corroborating information as to understand why they're there. Remember the mnemonic DONT, D-O-N-T, dextrose, oxygen, naloxone, and thiamine. But don't give it in that order, lest you precipitate Wernicke's encephalopathy. Rather, always give thiamine before dextrose, so that way, in the event that a patient has low vitamin B1 stores, you don't produce or precipitate a chronic long-term encephalopathy. Next, one of the things I'd like you to walk away with is understanding how to test for subtle signs of hemiparesis. One of the classic things that I do is I check for something called satellite sign, and it's evident in the video that you're seeing right now. No audio is necessary to watch this video. What you're doing is you're watching the patient make fists and circles like this. And if a patient had weakness in the right side, they would not move that arm as much, and it would be like a planet with a strong arm satelliting around it. So if a patient does this, they have weakness in the right upper extremity. If the patient does this, then they have weakness in the left upper extremity. Satellite sign is one of the most beautiful ways to assess for very subtle weakness that you might not pick up with individual motor testing. Another way to check for subtle signs of hemiparesis is to look for pronator drift. Many of you have been taught to simply ask a patient to extend their arms and to close their eyes. And in my opinion, you will miss most cases of subtle hemiparesis if that's all you do. You need to ask the patient to extend their hands, elbows straight, close, and high. And then with eyes closed, shake your head no. And often as they shake their head no, then and only then will you see the drift of the weak upper extremity as evidenced in this video. Finally, you'll notice that one of the other things that I always do whenever I'm triaging patients in low and middle income countries is I immediately walk up to the bed, even before I start talking to the patient, and I uncover their feet. A laterally rotated foot indicates usually one of two things: a hip fracture, which is usually quite evident because the patient's complaining of hip pain, or subtle hemiparesis. This patient has weakness of the right lower extremity. This patient has weakness of the right lower extremity. And this patient has weakness of the right lower extremity. Now, finally, you can take your physical exam findings that you've already identified and try to pair them with upper versus lower motor neuron testing. Babinski's sign, for example, is one of the most classic abnormalities that we look for in a patient with a lesion in the central nervous system. Remember that a lesion in the central nervous system, in order for it to produce Babinski's sign, must affect or interrupt the corticospinal tract, that descending motor tract. So a lesion just anterior to that tract or a lesion just posterior to that tract, even though it's in the central nervous system, may not produce Babinski's sign. Here's a video of Babinski. Notice that I don't need any special tests to do it. I take my thumb and I apply a noxious stimulus to the lateral aspect of the foot, and then I curve around medially towards the great toe. And the only thing that I look for is extension of the great toe. The presence of Babinski's sign in a person over the age of 8 months of age implicates pathology that is lesioning the descending corticospinal tract. Well, one last thing that we need to talk about, and that's vasculature, because vascular lesions are so common. Every doctor should be able to say there are 4 arteries that feed the brain, 2 carotids and 2 vertebrals. The carotid artery bifurcates into the middle cerebral artery and the anterior cerebral artery. The vertebral arteries anastomose into the 1 basilar artery and then again bifurcates into the posterior cerebral arteries. It's important to know that the carotid artery and its distributions are called anterior circulation. And it's important to know that the 2 vertebral arteries, which mesh into the 1 basilar artery and then bifurcate into the posterior cerebral arteries, are called posterior circulation. And so when you look at a brain, you should be able to draw a line across it and say vascular lesions up here are from anterior circulation lesions and vascular lesions in this part are from posterior circulation. So look at that brain. Look at the brain stem and look at where those cranial nerves are and see that they are all fed by posterior circulation. So you can imagine that posterior circulation lesions have the ability to cause coma, to cause locked-in syndrome, and to cause cardiorespiratory collapse. And so you can imagine, therefore, that posterior circulation vascular lesions are very potentially devastating and have very high risk for morbidity and mortality. Anterior circulation lesions, especially on the left, can affect language, Broca's and Wernicke's areas. It can take away language. So you want to be very careful and understand why we care about whether or not you've got an anterior versus a posterior circulation and whether you've got a left or right-sided lesion. Now, middle cerebral arteries are large. If you opened up your hand and placed it over the lateral convexity of your brain, that's the distribution of the middle cerebral artery, and it's large. And so lesions of the middle cerebral artery can affect the motor and the sensory homunculus on the lateral convexity, which would largely affect face and arm more than leg. So a classic MCA stroke would produce face and arm more than leg, sensory and weakness abnormalities, as well as aphasias if the lesion is on the left side of the brain, because remember that for most people, language lies on the left. The anterior cerebral artery feeds the middle aspect, or the parafalcine region of the brain. And in respect to the motor and the sensory homunculus, that's where the leg is represented. And so lesions of the anterior cerebral artery tend to produce motor and sensory changes of the leg. And because right in that same area is a voluntary center for voiding, patients can have problems with urinary incontinence. The frontal lobe is largely also fed by the anterior cerebral artery, and so personality changes can also be seen with anterior cerebral artery lesions. Remember the maxim in neurology. Anterior cerebral artery lesions produce leg more than face and arm. Middle cerebral artery lesions produce face and arm more than leg abnormalities. And deep strokes, deep in the brain, affect all of those coalescing fibers as they've come down. And so deep lesions produce face equal to arm equal to leg, motor and sensory modalities. Now, if I could take my brain out of my skull and hold it like this with my hands, where my hands touch my brain is posterior cerebral artery. The posterior cerebral artery feeds the inferior and posterior aspect of the brain. There are no corticospinal tracts that run through this area. The only thing that you really see in posterior cerebral artery lesions are visual changes, hemianopsias. And so PCA strokes are very commonly missed because the brain, strangely enough, kind of fills in for the visual changes that you get when you lesion the PCA and the visual radiating fibers. Well, here's that descending corticospinal tract again, with its cell bodies originating in the precentral gyrus of the frontal lobe and descending down the corona radiata, skirting through the internal capsule, down below through the midbrain, the pons, the medulla, decussating where the pyramids are at the cervical medullary junction, and then descending to the contralateral side of the brain. And you guys know that the middle cerebral artery therefore feeds the face and the arm. And you know that the anterior cerebral artery feeds the leg. And so now, what is this all about? This was all about the fact that there is no single test, no matter where you are in the world, that can assess the integrity of the entire nervous system from cortex to muscle. And so you have to localize lesions because different disorders affect different levels of the nervous system that we were talking about. And so you're talking about infectious and tropical neurology today. And so it's important to remember that the differential diagnosis of lesions that affect the cortex are very different than the lesions that affect the subcortex. When you're practicing in a low and middle income country and you see a patient who has a cortex lesion, you need to think about disorders like epidural abscesses, subdural hematomas, epidural hematomas, depressed skull fractures, benign brain tumors called meningiomas, cryptococomas, tuberculosis that loves the surface of the brain, anterior circulation strokes such as the middle cerebral artery or the anterior cerebral artery, Angiostrongylus catinensis, brucellosis, and malaria. Go one step deeper into the subcortex and now the disorders start to be a little bit different. You start to see things like intracranial abscesses, interparenchymal hemorrhages often from untreated hypertension, deeper brain tumors, tuberculomas again, cryptococomas, viral encephalitides love the deep brain, anterior circulation strokes. In HIV positive and immunocompromised individuals, this is where progressive multifocal leukoencephalopathy, or PML, from the JC virus lives. Primary CNS lymphoma in a poorly treated HIV patient who's had HIV/AIDS for a long time. And finally, classically, this is where toxoplasmosis goes. Now go to the brainstem, super high-priced real estate, where small lesions produce immediate abnormalities because of the close proximity of such eloquent structures. Lesions here can't get very big without being noticed. And so this is where you start to see things like vascular emboli from dissections of the vertebral arteries, which produce neck pain and focal neurological deficits. Small, rapidly growing, high-grade brain tumors live here. Encephalitis of the brainstem, rabies, cysticercosis, African trypanosomiasis or sleeping sickness, and finally listeria. Go one level deeper and now we're in the spinal cord. Now the lesions become absolutely different. Things like herniating discs, stenosis of the cervical and lumbar spine, tuberculosis of the bony vertebral column producing Pott's disease, poliomyelitis, and polio-like viruses like West Nile virus classically love to affect this area. Epidural abscesses, not only in individuals who are immunocompromised, but those who are also IV drug users. Schistosomiasis because of embolization of eggs to the spinal cord. Syphilis, which, as we talked about, loves to affect the dorsal columns and produce sensory dissociation, and the same is true for vitamin B12 deficiency. Transverse myelitis of many etiologies, which can be infectious or para-infectious. HIV vacuolar myelopathy in poorly treated HIV/AIDS patients. Conzo, or cyanide toxicity from improperly cooked cassava. Latherism, which is somewhat similar, and prostate metastasis, which occur everywhere, whether you're in a high-income country or a lower and middle-income country. Now go one step distal to this and we're outside of the central nervous system, or we're at the level of the spinal nerve root. The disorders that you think about here are herniating discs, metastatic cancers to bone like prostate cancer, avulsions of the nerve roots from trauma in a motor vehicle accident, para-infectious entities like Guillain-Barré syndrome, which classically manifests with low back pain following a GI or respiratory illness, that then produces ascending sensory symptoms, ascending weakness, and areflexia throughout, and other infectious entities like cytomegalovirus and varicella zoster virus. Take one step peripheral, now we're in the peripheral nervous system, the peripheral nerves. Peripheral nerves can convey motor symptoms, sensory symptoms, and autonomics. And so you have to remember that the disorders that affect the peripheral nervous system can affect motor, sensory, and autonomics. The classic disorders that we always think about are diabetes, infections like HTLV1, and my goodness, leprosy, which we've all learned about over and over again, which produces anesthesia, especially in cooler parts of the body. Many medications, dapsone, vincristine, are classic ones that can do this, as well as isoniazid. And any of the old HIV drugs that started with the D, DDI, DDC, D4T, are classic to produce peripheral neuropathies. Vitamin deficiency, like B1 in alcoholics and people that have severe gastric ulcers and gastritis. B12 deficiency from pernicious anemia, from tuberculosis of the ileum, and from Diphyllobothrum latum. And finally, toxicities like from improperly cooked cassava and alcohol. Lesions of the neuromuscular junction would be next, distal. And disorders here include things like myasthenia gravis and Lambert-Eaton myasthenic syndrome. Granted, those are not seen very commonly in low and middle income countries, but botulism is. Snakebite envenomation is seen all over the world and classically can produce neuromuscular blockade, especially if the snake that's biting you is a lapid. Chemical ingestions, specifically organophosphate poisoning, from either accidental poisoning or from purposeful overdose as a way to attempt to commit suicide. And finally, most distal to the neuromuscular junction is muscle. Muscular dystrophies like Duchenne-Becker's muscular dystrophy and myotonic dystrophy can occur in anyone because they're genetic mutations. You can attain acquired inflammatory myopathies like dermatomyositis and polymyositis. And for the disorders that are a bit more unique and germane to infectious and tropical medicine, we think about disorders like trichinosis and mitochondrial cytopathies from HIV medications. You can see now why simple localization and the application of several of the simple recommendations I gave you for localization will help you greatly as you're approaching patients in clinics and in triage when you don't have CAT scanners available and when you don't have MRI scanners or you don't have nerve conduction studies and needle EMG. To the best of your ability, you try to localize lesions in the nervous system from cortex, subcortex, midbrain, pons medulla, cerebellum, basal ganglia, spinal cord, spinal nerve root, peripheral nerve, junction, and muscle. And you think about, now where is this lesion? Now what are the disorders that affect this lesion in the nervous system? Okay, now what can I do to try to identify what disorder is causing this patient's specific constellation of symptoms and signs? Thanks so much for taking the time to listen to this, and I hope that this helps you greatly as you approach your next patient that you see in triage.